It is just a huge honor for me today to be podcast interviewing David Landwehr, D.D.S, MS, serves as a frequent teacher at events focusing on endodontics and oral pathology. His ongoing work as an opinion leader has positioned him at the forefront of modern endodontic treatment. Dr. Landwehr's teaching focuses on techniques used daily in his clinical practice that are efficient, evidence-based, and attainable for any practitioner. A Wisconsin native, Dr. Landwehr studied as an undergraduate at the University of Wisconsin-Madison and went on to earn his D.D.S at the University of Minnesota. From there, he earned an MS degree and certificate in Oral and Maxillofacial Pathology at the Ohio State University, followed by specialty training in endodontics at the University of Michigan. Since returning to Wisconsin in 1999, he has provided exemplary care to patients in private practice setting. It really is a huge honor to have you come on the show. I'm a big fan of yours, and I know my homies like the back of my hand, and half of them hate molar endo. And what would you say to, and even in dental school, I mean, 25% of our podcast listeners are still in dental school. Shoot me an email, howard@dentaltown.com. Tell me your age, where you're at. But what would you tell kids in dental school that already have made up in their mind that they hate molar endo?
Yeah, they need to change that mindset, because I know if I can do it, anybody can do it. Now, what's the difference between me and them? I've done it for 20 years, so I've got a little bit of experience, and I've made all the mistakes. You've got to be willing to make some mistakes, okay? There's a learning curve. There's a process to it. Best to learn and do those mistakes, create those iatrogenic issues out of the mouth, okay? Do some practice teeth. There's no reason that you got to jump right into the most complicated molar anatomy straight away in the mouth. Access into some teeth, cut through some teeth, see where the canals are, access some canals out of the mouth, take that experience and that skill set back into the mouth. Okay, so doing some things out of the mouth and getting some level of experience, and by all means in dental school, do as much as you possibly can. Push the limit. That's the time to get the experience. That's what you're paying for. That's why you're there.
But it's literally frightening, though. I mean, they're coming out of these private schools where they pay $100,000 a year tuition. They've got $350,000 to $400,000 student loans, and they tell me that they've done 3 root canals, and they were all single canal teeth.
Right.
It's like,
and 3 for some is many. Some schools are getting out doing 1, 2. Some schools are giving credit for watching a resident do a root canal. And from my experience, that is not a good way to learn. Okay, you've got to be in the trenches doing. This is what we do every day, all day. This is why we can make it look so simple. The other thing for the young clinician as they get out, partner up with an endodontist. It's not realistic for you to think that you're going to immediately out of school do every case that presents to your office. Partner up, build a relationship, send them a bunch of cases early on in your career when you're inexperienced, when you're not comfortable, but that comes with a caveat. Get into their office, see how they treat patients, see what they do. Take those techniques, bring them back to your office. Now you're going to start to see, okay, I can do this one. This one's within my realm. This is my skill set. Send out the ones that are going to take 2 hours, 3 hours, where the patient is going to say, well, I'm never going to do that again, because then they're going to start looking for a new dentist. When people have bad experiences, they love to tell people about bad experiences. But when it goes smoothly the way it's designed to go, they're not as apt to tell as many people. So partner up with an endodontist, and if that endodontist doesn't want you in their office and doesn't want to share their knowledge and skill set with you, find a new one that does.
Yeah, I mean, a lot of them think in fear and scarcity, and you go ask an orthodontist for help on an Invisalign case, or asked to watch a periodontist place an implant, and they're like, no. And it's like, well, it was still a great sales call, because you just realize this guy said no and thinks in fear and scarcity. And the next one will think in hope, growth, and abundance and form a relationship with you. And but they're so shy. By the way, I have to give it to you. You have the best name in endo, obturate.com, OBTRA.com. That is the coolest damn name. I almost wanted to podcast you just for that damn name, Obturate. It is. It's just amazing. And I don't want to tell them it's your email address too, because then they'll figure even that out. But but it is.
It's been my email handle since the 90s.
Oh my gosh. Going back to the 90s, you've been doing this for 2 decades. What's significantly changed in 20 years of technology from when you started this 20 years ago?
Well, when I started, we were on the cutting edge of rotary endodontics. So taking it from doing purely hand files to now doing some mechanical instrumentation, but mechanical instrumentation after significant hand filing, because the quality of the metals that we're using in first generation nickel titanium, they just weren't up to snuff. Not anything compared to where we are today. So the ability to mechanically instrument a root canal has evolved tremendously. It was initially multiple instruments, multiple tapers, 5, 6, 7 instruments to create the final shape. And now I can create that final shape in my clinical practice using 2, maybe 3 instruments. And I'm no different than anybody else. I'm a private practice clinician. I'm cheap. I'm lazy. I want to be effective. I want to be efficient. If I can do it with 1 instrument, I'm not going to do it with 2 or 3. And if I can do it for $5, I'm not going to do it for $25. But the one thing I won't ever sacrifice is outcome. So it's all about trying to achieve clinical success each time and every time. So the ability to mechanically instrument the root canal system has been probably the biggest long-standing change in the 20 years that I've been doing it. But more recently, in the last 5 to 10, of course, cone beam. For a decade, I would say to my patients, hey, if only we could see this anatomy in 3D, or we could see where this resorption goes, or we could see where the inferior alveolar canal is relative to this root end, that would really make a difference in treatment planning and what we might do from a retreatment perspective or a surgical perspective. And now we have that, right? We can get that information in each case, every case, or when we think it's clinically relevant, when it's going to potentially improve outcome, when I'm going to learn something, or I'm going to be able to better predict an outcome for my patient. So those have been the 2 really nice things that have occurred. And we continue to evolve. We're on the cusp of the irrigation revolution. That's what comes next. So when we look at overall success rates in endodontics, we've done well, right? Our success rates are high. Could they be better? I'd like to think they could be better. The one thing we've not been able to do over the last 20, 30, 40 years is deal with microanatomy within the root canal system. We can clean and create a very dense white line within the main canal, but that may not be everything that determines success. Success may ultimately be determined by how clean we get the microanatomy. And I think we're knocking on the cusp of that irrigation revolution.
And what percent of the bacteria, fungi, microorganisms are mechanically removed, and what percent of all those organisms is still there and would only be and have to be gotten with irrigants?
Yeah, it's scary. It's scary when we talk about these numbers. If you look at Ovi Peters' classic study on instrumentation of the root canal system, about 30% or just over 30% of the canal wall is untouched by mechanical instruments. You can translate that into about 30% of the biofilm is left behind. So if we don't have an adequate way to clean into the main canal, irrigate into the microanatomy, we are not going to be able to remove that biofilm and those microorganisms from the canal system. The old school concept was that instruments would shape and irrigants would clean, and that would absolutely be the case if the bacteria were simply free floating in the canal, but they're not. They're in a firmly attached biofilm to the canal wall, and if we don't physically disrupt that biofilm, we're not bringing those bacteria out.
So you said a couple times already that we're at a cusp of a revolution of irrigants. Why do you?
I hope
why
so.
do you say that? What do you see around the corner that thinks that irrigation is changing?
Well, we've had in the last several years, we've had some technologies in endodontics that have evolved. One of them is the Endoactivator. This is a very simple and straightforward way of moving irrigant around within the root canal system after creating final shape. Photon-initiated photoacoustic streaming was a light source used to disrupt biofilm. They've gone, by the way, a company named Sonendo has purchased the PIPs, the photon-initiated photoacoustic streaming, and sort of shelved them. And the Sonendo folks are using sound energy and a 8-minute flush of sodium hypochlorite and EDTA within the canal system with much smaller shapes than we would traditionally create doing endodontics with 04 and 06 tapered instruments. and showing some compelling results. Now, that's not a technology that I've yet incorporated into my practice, but I have several colleagues that have. From my perspective, I'm a bit conservative. I still think it's an unproven technology, but I hope it can do what they say it can do. Because I think it would have the ability to transform what we do and ultimately yield a higher success rate.
People have been talking about lasers too. Do you think lasers will ever be a part of endodontic canal cleaning?
Well, they sort of have been, and they've sort of come and gone in some respects. Delivering an effective light source deep within the root canal system and then into the microanatomy, I think, is the challenge. So I'm not sure that the light source is the way to go. The sound energy and creating the acoustic streaming that Sonendo is going after, that makes some sense. There's also some, I think, very compelling research, things that have not yet hit the marketplace. One of our colleagues in Toronto is doing some very interesting work with nanotechnology in order to be able to deliver irrigant truly into the microanatomy within the root canal system. And I think that is potentially a very transformative technology. This is something that's still in the laboratory setting. It's not something that's evolved yet into the clinical practice. And that's why I say we're sort of on the cusp of that revolution. We're not there yet, but I think this is a very active and important area of research in endodontics.
My homies get mad when someone's saying they do a composite and a bonding agent, but they don't mention the bonding agent. You've mentioned a lot of things. I know what they're thinking. When you start a root canal, do you start with hand files? If so, which one? And how far do you hand file your mechanical glide path before you switch to 300 RPM night tie? And what file are you using?
Yeah, so I have really evolved tremendously in how I create a glide path now compared to what I used to do. It used to be significant hand filings, 10 file, 15 file, 20 file. But the 15 and 20, these are stiff files. And that's a lot of work, and for a lazy guy like I am, I don't want to do that much work because I don't need to. I used to have to do that. I don't have to do that anymore because the quality of the metal will allow me to simply take a hand file. And it sounds crazy when I say this to people, but the majority of teeth that I treat, I could treat with a 10 file that doesn't have any flutes on it. All I'm really using the 10 file as is a gauge. Where can I comfortably put the 10 file? Because that will allow me to know where I can then put a rotary file. If I can put, if I have a 20 millimeter tooth, and I can immediately put a 10 file, 15 millimeters into that canal, and I haven't bound the file, I haven't met any resistance, I know that I can comfortably take a rotary instrument, like an orifice opener. So I use a 2008 Vortex orifice opener. If I can take that instrument past the dentin triangle and open up that shape, when I put that 10 file back in, it's not going to bind anymore at 15 or 16. It's going to continue to travel down to the apex because the apex is bigger than the 10. So if I travel into the canal with that 10 file, I haven't used it, I'm not pushing it, I'm not pulling, I'm just gauging. I will then go with a Wave 1 Gold glider, Wave 1 Gold glider, which is a 15 at the tip, and that's a reciprocating motion. And I will take that 1 millimeter short of where I meet resistance with the 10 file. And by alternating the 10 file and the Wave 1 Gold glider, I can make these incremental steps into any and all canal anatomies, irrespective of size, shape, or curve, because the apex is always going to be bigger than a 10 file.
So Wave 1, that's Dentsply Sirona, and actually their endo division started with you like Ben Johnson's company, Tulsa Dental, which is now owned by Dentsply, which then married Sirona. Is that your key rotary file, Wave 1?
So as an endodontist, some cases on a referral basis, it's like anything in biology. The cases that I see, in essence, make a bell-shaped curve. Okay, there's a bunch of them that fall into what I would consider standard molar root canal anatomy. And for those standard anatomies where I can fairly easily make and recreate the natural glide path, I'm going to do Wave 1 Gold instrumentation to create the final shape. Because again, it's a single file reciprocating system. It allows me to be efficient. I don't have to try to reinvent the wheel. I'm not using 7 or 8 instruments to get the end result. But again, none of that matters. All that matters is outcome. But for those more straightforward cases, that's what I'm going to do. In the cases that are more complicated, where I need multiple files in order to sort of sneak up on the shape because it's just a little smaller, a little longer, more curved, whatever it might be, or a combo of these things, then I'm going to use a file system where I need maybe 2 or 3 instruments to create the final shape. And in that scenario, I tend to gravitate towards ProTaper next. And in the most complicated root canals, smallest, longest, most curved, the really weird and wild ones, I'm going to use Vortex Blue, which is 04 or 06 taper, 15 to 50 in size, 500 RPM. But now I'm going to be talking about 5, 6, 7 instruments to create the final shape. So it's a more demanding technique because the anatomy that I'm treating there is more demanding. But it's going to be a much smaller number of cases. We're talking about a couple standard deviations away from that part of the bell-shaped curve.
And where did they get the name Vortex Blue? Where does that come from?
I don't know where the vortex comes from, but the blue comes from a oxide layer that forms on the outside of the metal. This is all post-grind heat treatment metal, which basically means that after the nickel titanium blank is filed into the appropriate shape, for Vortex Blue, it's going to be 04 taper or 06 taper. There is a series of heating and cooling treatments that are done. These are all proprietary. And an oxide layer will form on the outside of the metal. In the case of Vortex Blue, it happens to be a blue color. And basically, what the manufacturer is doing is looking at the design principles. We're talking about a 500 RPM standard taper, not variably tapered instrument like a Wave 1 Gold. So just a traditional 04 taper, and they're looking at what metal will work the best in that file design, a 500 RPM 04 taper. And they're in essence marrying the metal to the file design, which is designed to then increase our safety factor for clinicians, to have a more cyclic fatigue, more flexible, yet efficient cutting instrument out of the package compared to what we had been doing with first and second generation nickel titanium.
Well, the definition of vortex, a mass of whirling fluid or air, especially a whirlpool or a whirlwind. We were caught in a vortex of water. Synonyms: whirlwind, cyclone, whirlpool, black holes, even one. So which one of those words do you like the best for vortex?
Whirlpool.
Whirlpool. So what percent of your practice is retreats?
I'm lucky. In Madison, Wisconsin, I get to work with a group of very skilled clinicians. Maybe I get some of the credit for this because we've done a lot of work over the last 20 years of helping my GP colleagues pick the winners, right? What ones are they going to handle? What ones are they going to do well? What ones should they send out? What that's done is it's kept my retreatment rates low. Historically, my retreatment rate is about 25 to 30%. Many of my colleagues around the country, 50, 60, 75% of what they do in their day is retreatment. And one of the reasons I do this stuff, one of the reasons I put content out, one of the reasons I go out and teach and talk, and one of the reasons I allow people into my office to see what I do is to keep that number down. I want that number to be as low as possible for everyone.
Does that mean you're going to build a course on Dental Town someday?
Sure.
I'm telling you, they love it. We've put up 400 courses. They're all ADA, AGD approved, and I mean, we're coming up on 1 million views. That they just sit there on their iPhone. I mean, even during games, a dentist told me the other day, he doesn't even care during a football game when there's commercials because he just instantly starts checking his email, his smartphone, of course, on that. But that is so cool that by working with your value chain, your referring dentist, that you've lowered the retreatment rate. But when you do, even at 25%, when I think the 4,000 endodontists, if you just looked at insurance billing, it would be well over half of retreats. When you, even though yours is only a quarter, what do you think causes most of the retreats?
Well, by far and away, the most common tooth that I retreat is the maxillary first molar. And by far and away, the most common reason for retreatment of that tooth is the missed treatment or inadequate treatment of the MB2 canal.
Yeah, and do you think that's because they were looking at it? Do you think they just weren't looking for it, or is it two-dimensional radiography instead of three-dimensional CBCT?
Some of it is simply not looking. I think that's the exception rather than the rule. It's tricky, okay? Where I was taught to look for it and where it actually exists are not one and the same, okay? I was taught to make this triangular access opening from the mesial buccal line angle back towards the palatal, and that the MB2 was going to live somewhere in that line. And that can be the truth, but that is not the rule, okay? From my perspective, the MB2 canal can live straight lingual to the main MB canal. And if you take a bunch of maxillary molars out and you flip them over and you look and see what's actually the most mesial portion of that entire tooth, it is the lingual wall of the mesial buccal root. So many times the MB2 is actually more mesial than the main MB. It is oftentimes subpulpal floor, so you have to be willing to dive into the floor a millimeter or two to go find it. And it can be very close to the main MB, or it can actually be very far lingually placed, almost to the palatal orifice. So it's anatomical variability, I think, is what really leads to many folks not finding or successfully treating. And it's really, it goes back to what we all learned in dental school. Never touch the pulpal floor. But if you're going to find the MB2, you have to. You have to be willing, you have to know where to look, because there's a roadmap there telling you where to look, and you have to be willing to do it.
So then what would be the number 2 tooth?
Number 2 is the mandibular first molar, and that's going to be distal roots. So that distal root is, the misconception is that it's a single root from orifice to apex. And if it is, which it often is, it will be broad in the buccal lingual dimension. So what many clinicians will do is create a white line. And I'm very opposed to the white line. Now, I want beautiful white lines in my root canals, but more importantly, I want clean canals before that beautiful white line goes in. So if it is a broad buccal lingual canal space and they simply plow down the center without disrupting biofilm around the periphery, it will create a dense white line on the fill, but it's not clean. So in essence, you almost have to treat that distal root of the mandibular molar like it's 3 canals, getting that buccal portion, getting the lingual portion, getting the distal portion. And there's quite a bit of anatomical variability in the distal root as well. So many times 2 canal orifices that join to become a single canal at the apex, but oftentimes 1 that branches deep, so the wishbone shape. So we make that access in, create that shape down, and really have no idea that it is branched in the apical half. So it's really, again, it's the same issue. It's bacteria left behind.
Okay, so then I'm going to flip it around. She's just graduated dental school. She wants to know, what is the easiest tooth to do a root canal on?
The easiest tooth in the mouth to do a root canal on is the single-rooted, single-canaled maxillary central incisor in the 40-year-old patient that hasn't had a trauma. So that the pulp canal is the size that Mother Nature meant it to be.
So when you're practicing, what do you think are the common myths and what do you think is out there, that myths that dentists believe in endo that just aren't true?
Well, I think I see a lot of clinicians showing me cases and showing me white lines. They see a white line on a radiograph, and it is beautifully shaped, and it goes right to the apex. The length control is exceptional, and yet it hasn't worked. And they're of the misconception that the white line is all that matters. And that's really, it's important, but it's really a reflection of the shape and hopefully then ultimately the cleanliness that was created in the root canal system. If we look at our literature and dive into it, you can make an argument that putting gutta percha in teeth, although we understand the importance of it as it relates to seal and prevention of bacterial ingress, you can really make an argument that the sealing of the root canal system is not a very important part of what we do. It's all about the removal of bacteria. So I think the common misconception out there is that if I get a white line to the bottom, everything heals. And that couldn't be further from the truth.
So I just asked you what was the easiest tooth, and you described that nicely. For people that are just out of school, help them with case selection. What should they stay away from? What will they might think would be, oh, this is a good molar to start practicing on. not
Yeah.
knowing that this might be the worst molar to start practicing on.
Yeah, well, I think any tooth where you can see the chamber straight away. I think if you haven't done 30 or 40 or 50 root canals in your lifetime and you can't clearly see the pulp chamber, I think you need to stay away from that tooth. So that would exclude teeth in the molar region that are restored with crowns where you can't adequately assess the size of the pulp chamber. Now, you can potentially get by that with a bite wing angle, right? Something as simple as taking a bite wing, looking to see where the chamber is. Can I see chamber? If so, how far down is it from the occlusal surface? And if so, how far do I need to go in to get into that pulp space? And where can I go? If I see chamber 7 millimeters down and I'm accessing that tooth and I get down 5-6 millimeters, I know I have work to do. But if I get down 7 millimeters and I haven't found the canals, I know I need to go buccal lingual or mesial distal. And then I also can get from that bite wing angle an assessment of, hey, is 8 millimeters, 9 millimeters, 10 millimeters, where's the furcation floor? Where are bad things going to happen? Okay, so I think they need to be able to see the chamber. The other things that I think are imperative, you have to have a good angled preoperative radiograph. I'm not one that insists on a bunch of radiographs. I want one well-angled radiograph to look at anatomy and try to assess in 2 dimensions the curvature of the canals, right? How much curvature is there? Is there a fast break in the canal system? Do I see something is there anything in that radiograph that suggests the anatomy is going to be atypical? Okay, so that said, before I treat a tooth, I assume that every anatomy I'm going to encounter is atypical, and I'm never surprised.
So I want to know, how can I get one of those shirts? Set up straight so they can see on YouTube. That is I just love it. It says Obturate, OBTR8, Advancing Endodontic Education. And that is the website too, obturate.com.
Yeah, that's it.
Obturate.com. Do you sell that shirt on your website?
I don't. Nobody seems to want any of the swag except you, Howard.
Well,
but the good news is we can get you one.
Really? Do
Sure.
you have 3XL?
That might be a special order.
No, I'm just kidding. I may be fat, but at least I'm short, so I can still fit in those XLs. If there's one thing I can't even get my hands on after 31 years, is what the hell does standard of care mean? I mean, there's more definitions of standard of care than there are people, and how can any endodontist, how can any general dentist do a standard of care root canal if he doesn't have a CBCT, and the endodontists are using them, or he doesn't have a microscope, some Zeiss, or what's the one made in St. Louis, a global out of St. Louis, or a Zeiss out of Germany. I mean, can I be a standard of care general dentist doing molar endo if I don't have a CBCT and a global or Zeiss microscope?
You can. It becomes a little more difficult. So when we look at equipment, tools, and how they relate to standard of care, really the only piece of equipment in endodontics that is the standard of care is the rubber dam. When it comes to the microscope, when it comes to cone beam, when it comes to any of the irrigation adjuncts that we've talked about, these then become what might be considered best practices or state of the art. But the bottom line is the only piece of equipment that is standard of care is the rubber dam. So the bottom line is you don't need a microscope to be able to enter into and treat 4 canals. You don't need a CBC to know that those 4 canals are there. Are they going to help you? Yeah, they're going to help you. Okay. Me personally, I couldn't do an endodontic procedure without the use of the surgical operating microscope. Can I do endodontics without the use of a cone beam? Yeah, because I did it for a whole long time, so I don't have it or need it as a crutch. Does it make my life easier? Absolutely. Does it improve my success rates? I think it probably does. Certainly in some cases it's going to. So when it comes to standard of care, I think it's just important for our GP colleagues to understand that if I was doing a crown, my crown would need to be as good as theirs. And I can't do a crown as well as they can because I don't do it, right? That's not what I do. So when it comes to standard of care, when folks are treating cases endodontically, they need to be able to get the same sort of end results that we're getting as endodontists, right? And I'm not naive. 80% roughly, we can argue the numbers. Some folks say it's a little less than that. Some folks say it's a little bit more than that. But roughly 80% of the approximately 20 million root canals that are done in the United States each year are done by the GPs. And I just want everyone to do a good job so that it doesn't reflect poorly on me. I go to parties and people ask me what I do, and I have to tell them I'm a tooth plumber. Because if they find out that I do root canals for a living, they're going to tell me about the worst experience that they've had in their life, or the worst experience that their Aunt Mary Jane had. And that's just not how it has to be. That's how it used to be. Okay. So yeah, that's where I'm at with that.
Well, when you hear that story, you just keep looking at them in the eye and say, "Did you die? Did you die?" But I'm just kidding. So the rubber dam, it blows my mind. I know some of them are going to say, well, what if they use an isolite?
Well, I have a very simple answer to that question. It's one of the more common questions that I get when I am talking with my GP colleagues. Is an isolite a rubber dam? Well, the answer is no. The standard of care is the rubber dam. An isolite is not a rubber dam. An isolite is an isolite. So it's closer to the truth than nothing, but it is not the standard of care.
Yeah, I don't understand why they don't use rubber dam, and if they don't like placing them, well, then don't place it. Have your assistant place them. Numb up the tooth, go do a hygiene check, let someone else place it. But don't you think that you can do a root canal much faster and easier with a rubber dam?
Well, I absolutely can, because it's the only thing I know, and I don't know any endodontist that would disagree with that. So it's not like, it's not like there's a handful of us out there as true believers. This is us. This is us as a specialty. So it truly is the standard. A lot of things can happen. Files can break, perforations, all sorts of crazy things during the procedure. But a file getting away and being aspirated, swallowed, that's not something that you can recover from, right? And it's preventable. It's preventable not some of the time, but every single time with the rubber dam. So there's a safety factor there over and above the biological factor of we're going to get a better outcome with the rubber dam because we're not going to be constantly recontaminating our work field with bacteria.
And so I know they think, so the next question they're thinking is, okay, well, which CBC did you get? And which microscope did you get? Let's start with microscopes. Did you go global out of St. Louis or Zeiss out of Germany? Which one?
So I have global scopes. I've always had global scopes. And the reason is because when I trained at the University of Michigan, that's what I used there, and I felt comfortable with it straight away. From my perspective, earlier on, 10 years ago, the quality of the optics and light source in the Zeiss were actually, I think, a little bit more superior than the global, but there was still that comfort level that I had there. Now I think the quality of the light source and the optics between the two that gap has narrowed. So bottom line is, I don't really care what the manufacturer is, as long as there's some level of illumination and magnification. It doesn't even need to be a microscope, quite honestly. I think a lot of my GP colleagues, I see some really good endodontics coming from folks that are using loops and a light source, 4x, 5x. But there it's imperative that they have the light source, right? If you're going driving at night and you're going to kill the headlights and drive in the dark, just in the dark by feel with binoculars, well, in Wisconsin, you're going to hit a cow. Okay? You're going to be off the road before you know it. So you got to have a light source as well. So a light source and some level of magnification should get you to the truth. Yeah.
I'll tell you, you walk in the binoculars. One of my best buddies, Craig Steichen, one time for Christmas, I got him the Zeiss binoculars.
Mm-hmm.
I think they're the coolest things in the world. You can go outside before the sun's up, say you're elk hunting or whatever. It is the coolest thing, those binoculars. I mean, everyone who takes binoculars to a game, sometimes I'll say, can I look through those? And you look through them, and it's like, why do you even bring these? But those Zeiss binoculars, I don't know if Global makes the binoculars, but if you did 100 root canals, what % of the time would you use your microscope?
100% of the time. So Once the rubber dam is placed, and even sometimes with the use of the microscope, the rubber dam will be placed. From the time the rubber dam is in place until the time the temporary is in place or the tooth has some sort of coronal seal, I'm looking under the microscope the entire time.
At what X?
Somewhere 4x, 5x. And the difference is in one room I have a 4x scope with the lowest step, and in one a 5x. I can go up to 10, 12, 18, 20. But those higher magnifications, those are looking for cracks. Those are maybe doing a little bit of post removal. Those are magnifications where the depth of field is simply too shallow to work. So the great majority of the work that I do is in the 4 or 5x range. Okay, and that is very attainable with loupes and a light source.
Same question for CBCT. If you what brand, and if you get 100 root canals, what percent of the time would you get a three-dimensional picture of that tooth?
Yeah, so I have some colleagues that, so I'll answer brand first. I'm using CareStream. That I have a bunch of friends that use J. Merita, and I can sort of see a few differences in the image scan and quality between the two. There's also a significant difference in cost in the downstroke to get the equipment. So from my perspective, I think they're very similar. When it comes to percentage of cases, I have some colleagues that are using cone beam in every single case, and their rationale is I can learn something. I have a tool. Why wouldn't I use that tool? I don't know what I know unless I ask the question. And I get that. I understand that. However, from my perspective, because I've done it for a long time without, I don't feel that I need it in every case. I take it when I think it's going to be a benefit to me and or the patient. Retreatments, resorptions, surgeries, almost 100% of the time. I'm a big fan of an intraoperative cone beam. If I don't have a cone beam and I'm treating a maxillary first molar and I'm in that tooth and I've treated the 3 main canals and now it becomes MB2 time and I'm doing a little bit of search and that search is not giving me another canal, and yet I suspect there's another one there, I have a choice. I can take away tooth structure, or we can put the brakes on and I can get a cone beam. And by putting the brakes on and getting a cone beam, maybe I find out that there isn't another canal there. And I haven't then sacrificed any tooth structure in order to answer that question. So for me, on a percentage basis, somewhere between 30 and 40%.
Nice. And how many different irrigants do you use?
So I use sodium hypochlorite. I use 5.25% sodium hypochlorite, so that's stock out of the bottle. I use that early and often during the procedure because we understand that there's a volume effect to sodium hypochlorite and the effectiveness of it diminishes with time. So I'm constantly turning that over. In a molar root canal, 4-canal molar root canal, I'll typically use 5 ml syringes throughout the case. When I'm done doing the instrumentation, and that's when the sodium hypochlorite is basically done, I will do a final rinse with Q-Mix, which is a chlorhexidine and EDTA combo irrigant. And at that point, what we're going to be getting is a smear layer removal and a secondary disinfection simultaneously. And that may be a little bit more kind to the dentin than the traditional sodium hypochlorite, EDTA sodium hypochlorite regimen that we used for so many years.
There's a lot of, when I lecture in Cambodia, Vietnam, Indonesia, Malaysia, they always ask me the same question. I always say, how come Americans don't use hydrogen peroxide? What would you say to our Asian listeners? It's huge in China, it's huge in Southeast Asia. What would you say to the guy who asked that?
Yeah, so the bottom line, so for me, the prototypical irrigant would fulfill a variety of tasks. The ideal irrigant would kill bacteria. It would dissolve tissue. It would be as kind as possible to the dentin substructure so that we're not changing the biochemical nature and makeup of the dentin. And from my perspective, when we look at what hydrogen peroxide is going to do against what sodium hypochlorite is going to do when it comes to killing bugs and dissolving tissue, that's going to be by far and away a superior irrigant. So I don't think there's anything wrong with hydrogen peroxide. I just don't think it's as effective as other regimens.
So if you did 100 molars, what percent of the time would you use sodium or hydrogen peroxide?
What percent would I use hydrogen peroxide?
Yeah.
I don't.
Okay, and what percent of the time would you use a chlorhexidine, gluconate?
So I will use chlorhexidine as my standalone irrigant, replacing sodium hypochlorite in one clinical scenario. That clinical scenario is typically a mandibular second molar where a lingual cusp or two is gone, and I'm not convinced that I'm going to keep every drop of sodium hypochlorite in the tooth, especially if it's an irreversible pulpitis scenario. If it's a necrotic pulp scenario, I may still consider using sodium hypochlorite, because I know one thing for sure after doing this for 20 years, people do not like how sodium hypochlorite tastes. If I know I can't control every drop of it, I know I don't want to drink it. I know my patients don't want to drink it.
Yeah. Unless they're Russian or Irish, where they'll drink anything straight.
And they don't even care. Then they say, thank you, can I have one more?
And when you're irrigating, what percent of the time do you use the Endoactivator system kit that you mentioned earlier?
So I use it. Yeah, so I use an Endoactivator in virtually every case that I treat, irrespective of pulpal diagnosis. So irreversible pulpitis cases, necrotic cases, retreatment cases, and there's an irrigating regimen that I go through. When I've created the final shape in the root canal system, I will give a fresh 5 ml rinse of sodium hypochlorite. This is the deepest the sodium hypochlorite is going to penetrate into the canals because I've now created the final shape. And at that point, I will use the Endoactivator. The idea behind the activator there is to create turbulence within the canal system and bring out biofilm and debris. I will pull out that sodium hypochlorite, and there's a water rinse that's done. And then the Q-mix will go in, and that Q-mix is activated. So each canal gets about a minute of activation, 30 seconds of sodium hypochlorite, 30 seconds of Q-mix.
Another huge debate on Dental Town, and again, it's hard to tell what's myth, what's going on, but to one step or two step. And a lot of the debate focuses on if there's periapical pathology. So my question is, when do you one step, when do you two step? And I'm not talking about a country music line dance.
That's good, because I don't dance, but I'll ask you a question. I'll dance around the question by asking you a question. Do you have your appendix?
Yes.
Do you know anybody that doesn't?
Do I know anybody who's had their appendix taken out? No. I mean, patients on a health history, but no one personally.
Yeah, okay. Well, we'll go hypothetical on it then. If someone was having their appendix taken out, how many steps do you think they'd do it in?
One.
There you go. There's the answer to the question. Okay. But what's the difference from a biology perspective? The difference is when the appendix comes out, boom, we can see it, it's gone. Okay. We don't have that same metric. What limits us from an endodontic perspective is our inability to measure the absence of bacteria within the root canal system, right? So you can ask that question, are all the bacteria gone? And the answer is, we don't know. That's the honest answer. Okay. So when do I single visit versus multi-visit root canals? I'm pragmatic. I'm a clinician. So some of it has to do with what day of the week it is. I am more likely to place gutta percha into a canal system on a Monday than I am on a Thursday or Friday, if there is a necrotic case with a mild amount of swelling. But the real deal for me, the canal needs to be dry. Okay. If the canal is not dry, it is not going to see gutta percha, right? And what I've learned from my travels and travails here over the last handful of years, we can't even agree on what dry means, okay? I think dry is you can put a paper point in, you can grab another paper point, put it in, and it's still dry. Other folks define dry as, well, I took the paper point out and I immediately stuffed a piece of gutta percha in and there wasn't enough drainage to push it out, so that must have been dry. Okay, so we don't agree on that, and that's okay. Again, this is the practice of endodontics. There's no right or wrong answer. Okay, but really, from my perspective, if the canal is dry, if the canal is clean, if I can do my irrigation protocol, it is most likely going to see gutta percha, irrespective of diagnosis. Irreversible pulpitis, necrotic, retreatment probably doesn't matter. That said, a little bit of swelling earlier in the week, more apt to get gutta percha than something later in the week, because no one likes the weekend call. I'm pragmatic.
Here's another emotional question. Some people, you always are running into your endodontists at your study clubs and your study meetings and things like that, and some of them want to use like a Guttacore, a gutta percha with a carrier, but sometimes they feel bad and shameful that maybe it makes it hard to retreat. and their endodontist isn't going to like them if they're using a gutta-percha carrier. So I'll just be brutal. What do you think of Guttacore? And what do you think of gutta-percha carriers in general? And does it make your life more difficult, or is it just a non-issue?
Let's go carriers in general first, and then I'll go product specific. The bottom line is if you get a root canal system equally clean across the board, irrespective of pulpal diagnosis, you're treating 4 teeth in the same patient, and you do one with a rigid carrier-based obturation like a thermofill, one with a Guttacore, one with a silicone, one with a down-pack backfill like endodontists might do, you're going to see equal results, okay? The cleanliness is what matters. The problem that endodontists have with some of the carrier-based techniques is that a stiff and rigid carrier could be placed into the canal system, in essence creating a very dense white line and an optical illusion, something that looks like a significant amount of instrumentation was done, even though it wasn't. And a rigid plastic carrier then becomes, it's inevitably going to be retreated, or a surgery is going to be done, and taking those carriers out and or doing a surgical procedure, it becomes difficult. So as a whole, endodontists are not too fond of carrier-based obturation. That said, when you go to a carrier-based like Guttacore is a little different. It's all gutta-percha. So the carrier itself is gutta-percha. If we look at the amount of time required to remove a Guttacore carrier against a down-pack backfill fill or a rigid carrier-based like thermofill, it's actually easier to remove. So I'm not one that's anti-carrier. I use carriers in my practice. Okay, there are times when it is impossible with some of the anatomies that we treat to thermoplasticize gutta-percha deep within the root canal system using a traditional down-pack backfill technique. The only way to carry warm gutta-percha to the apex in those scenarios is going to be with the placement of a carrier-based obturation. So the bottom line is there's nothing wrong in my view with a carrier-based obturation as long as that canal is clean prior to the placement of the carrier. But the nice thing about a Guttacore is that if you don't have the shape, it won't go because it's brittle like gutta-percha. It will break on the way in. It will not get to the apex.
I want to ask you another bizarre question. This is Dentistry Uncensored. There are dentists that never ever place a post in a molar or bicuspid. I mean, they haven't placed a post one time in years. There's other ones who place a post in every molar root canal they do. How do you explain such a huge variance between I didn't place one last year to every tooth got one last year?
Yeah, it's interesting. It really becomes a clinician du jour type of decision-making tree. I have some of my refer partners that, irrespective of restorative status, they maybe put a brand new crown on this thing and everything is great, but it ended up needing a root canal, and they want a post sunk into the tooth, post base, so that they can place the post. And others, to your point, they will anything and everything to never use a post, and we see everything in between. So from my perspective, there's some changing and emerging literature in the endodontic community about the placement of posts, whether we're talking about a fiber post dual cure kind of system. Any post system where we're going to remove tooth to place the post, unless it's absolutely necessary to retain the core, is going to be diminishing the overall strength of that tooth. So, the way I look at this, the post is used to retain the core. The core is used to provide stability for the crown. Therefore, if we can retain the core without the use of a post, I would avoid using a post.
So here's the bizarrest question you've probably ever been asked. I hope I win the race of the most
you'd be
bizarre.
surprised.
Well, when I did 4 or 5 podcasts filmed on location in Tokyo, another dozen in London, more in Paris, where they have a government healthcare system, kind of like we have Medicare for over 65, and then each state has Medicaid for poor. But in their countries, they only give about $100 US for a molar root canal. And those guys tell me off the record, they wouldn't say it on the podcast, but they tell me off the record when they're drinking beer that they have to place a post in every canal because the benefit for the post is equal to the benefit of the root canal. So if you were lecturing right now to dentists in Tokyo, London, and Paris and said, I don't care what you pay, I either got to go bankrupt or quit, or do what some of their colleagues did, which is quit doing molar endo and extract the tooth and do an implant, because the implant's not covered. So if they do the molar root canal in Tokyo, London, or Paris, it's about $100 US. But if they extract it, they can do a $1,500 implant, which should make everybody really think about these insurance plans. But if you were lecturing to a dentist in Tokyo, London, Paris, said, look, dude, for insurance reasons, I have to place the post in every canal, which one would you recommend? Which would first do no harm? Which one would be the least harmful?
Yeah, so it would be a post system where no tooth structure was removed. So we have enough shape just built into the natural canal. So a fiber post dual cure composite type system would be what I would definitely recommend. You're going to get...
Name a brand.
Couldn't do it. Haven't ever placed one. That's the thing about the U.S. how we do this. There are some of my endodontic colleagues are doing the root canal, placing the post core, and even sort of roughing in a crown preparation and sending the tooth back to their restorative colleague. Whereas in other parts of the country, if we did that, my GPs would be very unhappy with me because that's sort of their thing. It's pretty straightforward for them to do. So it becomes a nice procedure for them, very predictable. So yeah, it would be a fiber post with a dual cure. Can't tell you a name or a brand at all.
Back to
I think there's a bunch of them out there though.
But in this post answer, you said one that doesn't remove tooth structure.
Yeah.
There's a lot of debate. I mean, there's some dentists that like the 0.08 taper, and then the other dentists are looking at those cases and saying, dude, that's too much destruction. You're weakening the tooth. How much taper is too much taper, and what size taper do you like?
Well, the most important piece of dentin that determines how that tooth is going to do long haul from a fracture resistance perspective is the pericervical dentin. So we're talking about a couple of millimeters above the level of the crestal bone and a couple of millimeters below the level of the crestal bone. So most of the instrumentation that I do is going to be variably tapered. So it might be 0.6 at the apex, and that taper is getting smaller as we come up. So I don't really like to talk about taper as much as maximum fluted dimension. Okay, so the maximum fluted dimension of a wave 1 gold primary, for instance, at D10, D11 is going to be just over 90. Okay, so if you think about typical Gates Gliddens back in the day, 50, 70, 90, it would be the size of a number 3 Gates Glidden exactly. Okay, so I really don't want it to get any bigger than that. So most of the instrumentation that I do is going to be it's variably tapered, but most of the apical instrumentation that I do, if it's wave 1 gold primary, that's 25 at the tip, so the master apical file dimension 25, and that's 0.7 tapered, and that's from D0 at the tip back to D3, 3 millimeters from the tip. So it's 49 at D3, but if we think about some of the classic instrumentation studies that were looking at the ability to deliver irrigant deep within the root canal system, they wanted something bigger than a 30, somewhere between 30 and 35. Well, 1 millimeter back from 25 with 7 taper is 32. Okay, so all of that math makes some sense from my perspective.
So there's been a lot of changes lately in sealers. Gosh, 30 years ago it was Grossman cement. Now
Sure.
There's ceramic sealers. Where's your thinking with sealers these days?
Yeah, that's a great question. I'm currently using AH Plus sealer. Okay, so it's a resin sealer. I've been using it for years, and that's why I'm currently using it. I'm using it because I've used it for years. It is, in my hands, predictable and has withstood the test of time. Some of the bioceramics are very compelling from my perspective, but I do have some issues with them as well. The set time of the bioceramic sealers can be exceptionally long. There isn't a sealer in the world on the market in the unset stage that doesn't have some level of inflammatory reaction associated with it. So all sealers in the unset stage are pro-inflammatory. If that sealer set time is extended, and we're talking about maybe over 100 hours. That's a long time to be eliciting an immune response. And that's neither here nor there, because that may be the exception rather than the rule. One of the main tenets of a sealer or an obturation technique, from my perspective, has to be retreatability. We all like to think our success rates are going to be 100%, but they're not. And if we have a sealer that in essence bonds to the canal wall, and we then go back in to remove the single cone of gutta percha and that high volume of sealer, there's going to be no way that we're going to be able to remove that sealer and in essence disrupt the biofilm that led to the failure in the first place. So it really becomes an untreatable scenario.
We went over an hour and I still have a few questions left, or can I go over an hour? Can I go into some overtime with you?
Keep going. Keep going.
Okay, well, there's basically two types of people who do root canals. There's either the apical barbarian who wants to get all the way to the bottom and a puff of sealer, or there's that little pulp lover who always wants to stop shy and have the apical stop. Would you say you're more of a pulp lover or an apical barbarian?
Well, I'm not a pulp lover, okay, because I'm a root canal person. I'm an endodontist. I think all the pulps need to be out of those teeth. You know, that's what keeps me busy. That said, when it comes to the puff of sealer, this is also something that's very regional. You know, you get into the Boston area, and they have this, no puff is big enough, right? They can't see enough sealer out the end. You get into Southern California, and if you don't have a puff of sealer out the end, they think you're short. So I'm not there, but I don't mind seeing some sealer out the end. What I really want is the maximum amount of gutta percha that I can get within the canal system. I want to use the sealer to get into the microanatomy. And every now and again, I get some puffs of sealer here and there and a lateral canal here and there. And that's all well and good. And when I see these puffs of sealer, you know, mid-root or an apical delta, you know, I give myself a little pat on the back and I walk out of the room and wonder, well, I see 3 or 4 accessory canals in this tooth. I wonder if there were 4, 5, and 6, right? We have no idea.
So, I know several dentists that if they did 100 molar root canals, every single patient would get PenVK and 20 Vicodin. And then I know other dentists who just are outraged by that. And I was seeing a big shift. I remember when I got out of school 30 years ago, the healthcare providers were the bad guys because grandma's dying of cancer and they wouldn't give her any pain med, and why is she in pain? She's going to die anyway. And so people started losing it. Now we're the bad guy again because we prescribe so many opiates that now we're blamed for a lot of the addiction. And then same thing with antibiotics, that people are getting immune to antibiotics, which is hard to explain the concern about antibiotics when 90% of all antibiotics are used in raising and put in our meat supply, cows, chickens, pigs. It's like if they seriously wanted to get serious about antibiotics, the first thing they do is remove from the farms. But again, I'm going to hold your feet to the fire. If you did 100 molars, what percent would get antibiotics? What percent would get an opiate?
Well, 100 molars for me is about a month's time. So I do somewhere between 25 and 30 molar root canals in a week as an endodontist. And in that week's time, I will prescribe an antibiotic or 2 and a pain medication or 2. Okay, so for the 100, we'd be talking about less than 10%. From a pain management perspective, I've never been one that's prescribed a whole bunch of narcotic-containing pain medication because it simply doesn't work as well as some of the other regimens that we have. A combination of ibuprofen and acetaminophen can be extremely effective. Will I prescribe narcotics? Absolutely. If someone comes in and they had not slept, the night before, and I think they're in for another rough night or two, they're probably going to get pain medication. And I said probably because it's not in everything. And that's why I for the folks that you described that prescribe to everyone, and for the folks that prescribe to no one, and everyone and I respect that. I understand that. I don't know that there's a right or a wrong answer. Okay. So for me, it really becomes on a case by case scenario. When it comes to antibiotics, it's pretty straightforward for me. If there's a drainage into the canals, if there is swelling, certainly if there's fever, lymphadenopathy, any sort of systemic implication, they are going to get antibiotic. The best way, from my perspective, to treat these infections that we're dealing with in the root canal system is to clean and shape the canals, right? If I have a sliver in my hand and there's infection around that sliver, the best way to get rid of that infection is not with an antibiotic, but by removal of the silver. Now, that's in an endodontist's office. We have the luxury of being able to very efficiently clean and disinfect root canal systems in a fairly rapid manner. And it's what we do, and it's what we're set up to do. For the GP who may not be able to do a complete debridement of the root canal system, is an antibiotic a pragmatic way to offset some of the swelling that might exist and some of the discomfort that might exist? Absolutely, right? So then again, it becomes a case-by-case basis. But for me, I'm relatively conservative.
My insurance friends, due to the dysfunction between the insurance companies and the dentists, they won't ever give me stuff I can publish and post, but they're always showing me stuff. One of the things that sticks out to me the most, why did the number of apicocectomies plummet over the last several decades? Why do you think the number of apicocectomies you guys are doing has been drifting downwards for decades?
I think it's multifactorial. I think we have another option. You know, back in the day, there were the options to hang on to that tooth out, and maybe not the restorative options available. Now with the ability to place an implant into many of these positions, I think in many instances, we're not even given an opportunity to discuss risks and benefits with the patient. I think a lot of times that's happening in the GP's office, and they're saying, hey, that tooth has had a root canal. We've done what we can do. It should probably come out at this point. And it's interesting that you asked the question, because when we look at our surgical success rates, we really need to make a distinction between microsurgery and pre-microsurgery. When we look at microsurgical success rates with the use of a surgical operating microscope and ultrasonic tips, line of sight, direct vision, our success rates are actually spooky high. They approach or exceed that of retreatment in many instances. But yet, I completely agree with you. I think I've seen this in my practice. The numbers of surgical interventions that I do now is probably at an all-time low. Part of that is also due to the fact that our orthograde success rates are high, right? If our first time around success rates and retreatment success rates are high, we don't need to go to the surgical approach.
And last question, what would you say, we hear this on Dental Town, it's a young kid, he's in endo grad school, he's becoming an endodontist, and he's asking the general dentist on Dental Town, should he learn how to place implants too? Do you think 10 years from now, endodontists are all going to be placing implants too, or do you place implants? Does anybody anybody in your practice placing it? Any of the endodontists in your practice placing it?
Yeah, I don't place implants. No, none of my colleagues, there are 6 of us in my practice, place implants. Back in the day, when we think about the introduction of a new technology into the dental realm and the placement of intraosseous implants, for us as endodontists, it probably made great sense, right? We're thinking about doing a surgery. We lay that flat. We see a crack in the root. And how much sense would it have made at that point to say, all right, let's take that tooth out and simply place the implant into that position? But we didn't. So we as a specialty said, you know, we're good enough here doing all of this instrumentation inside the tooth. The oral surgeons and the periodontists, if they want to start placing these implants, great. You know, and because that's the way that it went, I think that's the way that it will continue to go. Now, there are certain programs where implants are being placed from an endodontic perspective, but I don't think we're ever going to get the numbers and the experiences necessary where I would feel comfortable saying I'm a specialist at placing implants, right? I'm a specialist at doing root canals. I can clean and shape a root canal system. After doing this for 20 years, I get surprised, but it doesn't happen very often. When it comes to placement of implants without that skill set, without that experience, I think I'd be surprised all the time.
And you know, it always comes back to, I think the smartest healthcare economist in the world is Regina Hertzlinger at Harvard University. I was able to get her on the show after a few years, and she talks about the focus factor. She's been talking about that for 20 years, that people who do one thing, like say you asked about appendix removal, the focus factor and the faster they go, like if your average appendix removal surgery from start to finish is 10 minutes and mine is 20, the guy doing it 10 minutes will have a much greater success rate because they know what they're doing, they're focused, they do a whole bunch of volume of it, and they just really get a focus factory on one thing. And I've also had insurance people. I was lecturing to insurance symposium in Florida this year, and there's about 300 or 400 people in the insurance companies, and they were showing me data at the bar that if a endodontist do 100 molars at 60 months, 5% have been extracted, and if general dentists do 100 molars, 10% have been extracted. And I almost wanted to just like steal the chart and just like publish it anyway, but then they would never show me anything else again. But so yeah, so just get focused. David Landwehr, D.D.S, MS. His website is obtr8.com. Coolest name, obtrade.com. Man, it was a huge honor that you stayed at the, I can see out your window. It's dark now. You stayed after work for an hour to talk to my homies. I really hope you make us an online CE course or an article in Dental Town someday. I could listen to you for hours. I think molar endo is their hardest thing. Implants, a lot of them wouldn't even consider learning how to place an implant, but a molar endo, I think the average dentist out there, that's their hardest thing. And it was very, very fun to podcast interview you. Thank you so much for taking an hour of your time and coming on the show.
Thanks for having me. I enjoyed it. I'm looking forward to seeing everyone at the Townie meeting in Scottsdale in 2019.
Nice. Okay, I'll see you there, buddy.
All right. Thanks. Have a great night.
Thank you.